Well, good afternoon, everyone, and it's a great pleasure to be in Victoria. I'm Adrian Sakundiak from Calgary, where I think we're getting 25 centimeters of snow tonight. So to land with green grass out of the window was a wonderful feeling in the middle of February. And it's a great pleasure to be here with our friends from Privacy Analytics at the 19th Annual Privacy and Security Conference. My presentation will focus on practically how we implemented a data de-identification solution for the Alberta Ministry of Health and Alberta Health Services. And I'll get right to the details. I'll tell you what worked, what were some of the challenges, and some of our successes and where we're headed next. And I really want to map out that journey of what we did, how we did it, when we did it, who was involved, and why we did it. And guiding all of our work was our Health Information Act, which is our legislation that sets out the rules for collecting, using, and disclosing personally identifiable health information. My background is in healthcare. I'm a former hospital CEO and a health region CFO. Spent the better part of the past 26 years in healthcare. The past 12 years consulting into the health industry specifically, in the areas of data analytics, business analytics, strategy, and over the past few years around data de-identification solutions. So I hope to give you a really good sense at the end of my presentation of the journey we took, and if you're thinking of embarking on such a journey, what to expect. So I'll give you a bit of background of how we started in 2013. We're basically 5 years into the journey. Some of the stakeholders that were involved, why we did it, what was the business imperative, what kept us up at night, why would we even take this on, and our implementation approach. So how did we do it, right? That's the key, is how did we do it? And as a result of that, what was the business value derived from the solution, and the lessons learned and challenges, and what our next steps are. So essentially, we're about 6 weeks away from ending this project, which has been quite a journey, and essentially we are live with some data today, so I'm pleased to share that with you. So in early 2013, we really started the journey around not a software and not a solution, but an actual service, a mechanism where there's a formal intake process for research and non-research requests to get access to personally identifiable health information in a de-identified form. And what was born about 6 years ago was the Provincial Health Analytic Network and the Alberta Healthcare Data Repository, which were really bringing two secondary use data repositories together for use provincially between Alberta Health Services and the ministry. And so at that time, Colette and his team from Privacy Analytics were contracted in 2013 to provide, we didn't know where we were. So we really needed to get a sense of what's our current state from a maturity perspective, and a recommended future state, and a bit of a roadmap on how to get there, and then it would be up to us to enable that. So deliverables from that work included, like I mentioned, especially the roadmap and where we were. And so the work was done basically 5 years ago, so early in 2013. And so you're probably wondering, okay, so what happened between 2013 and 2016? And the Provincial Health Analytic Network program this project was part of 17 different analytic projects. So it took a while to percolate to the top in terms of funding and priority. And once we did do that, Alberta Health Services and the Ministry of Health issued a joint request for proposal to really work with a vendor that could provide us with leading best practices and a solution that we could develop and mature a data de-identification solution for Alberta. And so that was Privacy Analytics. And so the RFP was issued in November, and we started the work roughly in June. We kicked off. And it was really a joint effort between the ministry and Alberta Health Services. And just to give you a sense of, so Alberta Health Services is the largest integrated health organization in Canada. So we have over 110,000 employees and a budget over $15 billion. That's one single organization. So over the past number of decades, from the former legal health entities of a union hospital and so on, into districts, into regions, that's how AHS was born. And so obviously, like the number of clinical and administrative systems collecting data over the years is significant, and our ability to unlock that data and share it and use it for program planning, funding, allocation, and so on is very important. And of course, the other partner in all of this is the Alberta Ministry of Health, who would really set policy and provide funding for the Alberta health system. And the ministry would and does have such systems as the Pharmacy Information Network, physician claims, the registry, population registry, and Alberta Health Services as a delivery of these services would have, the admission discharge transfer, all the lab data, emergency room data, et cetera, et cetera. So often these systems and data are shared between the two organizations. So I wanted to give you a sense of the scale, scope, and magnitude of this particular initiative. Of course, privacy analytics, Khaled and team, of course, Sarah was instrumental in working with us on site to deliver the work. Their partner, MNP, one of Canada's largest business advisory firms, and my company, 2020 Management Consulting. And again, it was two separate implementations, one procurement, separate requirements, and essentially what we did was procured an enterprise-wide license for all of Alberta Health Services, which would include every single department and all of the government of Alberta. So even though we started with health, labor, transportation, education, et cetera, we're all part of this, and other allied health organizations, including Health Quality Council of Alberta, Alberta Innovates, and others. So we really did take a broad enterprise view of how we wanted to engage in this new service. Some of the project stakeholders, again, between both organizations, 2 executive sponsors, 2 business sponsors, a number of privacy experts, legal experts, our IT security, obviously led day to day with our analytics research team, architecture, infrastructure, service design in terms of how we're transitioning to operations, our finance team, contracting and procurement, and of course our vendor partners, as I mentioned. We had over 100 stakeholders involved at any point in time in this project. And so you can imagine having 2 organizations and 2 vendor partners, and I'm sort of in the middle, quarterbacking, coordinating, like how are we going to do this? Because, clearly we didn't have a recipe book that said, here's how you're going to do it. So it was really trying to stay one step ahead of how we were going to make this successful. Part of the business imperative around why we did this work, notwithstanding our legislation, the Health Information Act, we really lacked knowledge in industry standard data de-identification techniques, procedures, and practices. We were doing this work somewhat manually, somewhat inconsistently, and perhaps at times we were unsure of our manual algorithms and how we developed our anonymization techniques, and as a result we're maybe afraid to deliver that data. We wanted to eliminate that, and we wanted to really understand the risks in releasing potentially identifiable data. And Khaled referred to that earlier around the risk threshold and framework and the contextual factors we have to consider, and I'll get into some of those. Really, we lacked the risk assessment processes, guidelines, and templates. We didn't have a consistent method and process and standard operating procedures to guide us. So depending on attrition and turnover, whoever would come in would perform some of these anonymization techniques the way they thought, Algorithms perhaps were changed, not defensible, and so on. So we really lacked with that. And really, we had no way to measure actual re-identification risk of releasing de-identified data. Like, was our risk high or low, and based on what? And now we do, and I'll get into that. Audits, we talked about audits earlier with the Ontario example. Privacy and security audits were not regularly performed so that we could verify that the recipients of this de-identified data were following the conditions for accessing the data. So we've got information sharing agreements and other legal authority that guide the use and further disclosure of that data, if at all possible. Now, our ability to go in and audit their use of that data, who has access to that data, et cetera, is much cleaner than it was before. Clearly, our privacy groups and experts were not involved at all or much in this process. Today they are. Today they're very much involved in setting policy and understanding the methodology that is now used to de-identify this previously identifiable data. As mentioned, we had some homegrown tools that were used, relatively inconsistent, and we felt we really didn't have the defense mechanisms to support our work in case of a breach, which was fundamentally important to what we ended up doing now. So our implementation approach, and I'm going to try this cool deal here. No, it's not working. Again, for 3 months, it took 90 days to say, where are you at? What level of maturity do you have? And what's the roadmap to get to where you want to go? And so we really undertook a process review, understanding our current practices, our people skills, like how skilled were we in doing this work? We needed to make sure that we had an implementation plan and a map set forward, and that's what we executed on here. So you can see from June 2016 up till next month at the end of March 2018 is where we went through the planning, executing, and eventual transition to operations of this new service. So there was a tremendous amount of work that went into planning what we were doing. And part of it, as mentioned in the Ontario example, was identifying use cases of real business scenarios that we could then prioritize and translate that into the actual de-identification work. So once we implemented our Eclipse solution, essentially, installed, configured, tested, et cetera, started loading data. And by the way, we de-identified 100 gigabytes of data, 250 million records, so large data sets successfully. We really had to get some early successes during that process, and I did highlight, you might not be able to see it, but was a pilot project. So from July, August, September, which is a bad time with holidays and all, but we were time bound by this grant. We prioritized 2 use cases, one for AHS and one for the ministry, to demonstrate to our sponsors and to ourselves the business value that can be derived from implementing such a data de-identification solution. I'll get into more detail on what those 2 use cases look like. Some of the business value that we're seeing, we really now have a best-in-class DID solution and service, whether techniques, procedures, and practices. And 2 weeks ago, we met with our Office of Information Privacy Commissioner and provided an overview of the methodology and a demo of the product and what we had done, and received great feedback, very positive feedback. OIPC gets a lot of questions on such data de-identification work, and so arguably we would be carving a new path and leaders in developing this new service. A key part was developing the policy statements, the SOPs, and the business operating guidelines to drive our work. And That included a measurement of actual risk to de-identify the data sets. We now have a strategy for privacy audits. So based on the legal authority and the information sharing agreements, we have a mechanism to audit the compliance with the receipt of such data, whether that's universities, researchers, et cetera. And today we do have a mechanism where our privacy and policy and security groups are regularly involved in our DID practices. And again, as mentioned previously, that just didn't happen before. So we now have a service and a model that we can deploy provincially and scale accordingly beyond health. So we're talking all of government of Alberta and all of our health departments within AHS, which is no small task, as I mentioned. So what we had done with privacy analytics and MNP was reviewed our governance framework, developed a leading practice, state-of-the-art governance, risk management control framework. Those control points which measure risk were mapped to our business architecture. So we had some lineage between our governance framework. We had to map out our detailed workflows, and obviously that's important for our privacy impact assessment to OIPC. And we did that both for the research requests, where we've got some trust in folks that we've worked with in the past, and non-research requests such as educational purposes. And I mean, clearly the business value is that we've implemented a state-of-the-art software solution for DID, that being the Eclipse solution. And the methodology really fits within the requirements of the Health Information Act, which was very important for us to demonstrate. Again, now our DID services are defensible with key documentation. Out of every DID project that is run, we have documentation that outlines the work we did, the amount of anonymization, whether masking or de-identification, we applied to that data set. And that's key for our audit groups. And as I mentioned, communication with OIPC for this solution was and is key. So we are planning to meet with the commissioner herself, Jill Clayton, later in March to provide an overview of how we've rolled this out. And again, I think what we've done really is implemented a best practice process to manage risks for releasing potentially identifiable data. One of the key factors that we found during this project was, because it was a mile wide, was to break it out. So we really took 3 working groups to task, one being a governance working group, so identifying those key leaders in both organizations that could form that governance working group around the privacy and security policies, procedures, et cetera. And our approach was to work directly with the Ministry of Health, because theirs is different than Alberta Health Services. But for information sharing and learning, we came together cross-functionally between the 3 working groups. Likewise, for our process working group, we definitely shared in some of how we do things today, because a lot of the methods that are applied, when we go deep into the methodology around how we're classifying certain data variables, like Khaled talked about earlier, really impacts your risk threshold. So the more we could understand and be consistent in applying that on that data was critical, because we didn't want 2 different answers from 2 different groups. So there was a lot of work in that component. And also our architecture and infrastructure. What kind of platforms do we need? What kind of servers and disk space and horsepower to run very large data sets through these systems? So again, that would definitely be a great takeaway in terms of a best practice. So again, as I mentioned earlier, we did categorize about 20 use cases, which are essentially business scenarios that were already in use to date by both organizations, and prioritized, reviewed that with our sponsors, and went through the 90-day pilot project. To break it down even further, we leveraged a sprint approach where we had small bursts of successes, because what we found was not only was it really not well known to privacy and security or analytics around what we were doing, but it became quite large. So if we separated it into short sprints and short wins, we found we could continue with the momentum. And we did have regular daily scrum meetings, which shared the good, bad, and the ugly. Like, what are we working on today? What worked, what didn't work? And because I was deploying both, I could share between the two organizations, which was, from my perspective, very valuable. And again, as I mentioned, we de-identified very large data sets, upwards of 250 million records and over 100 gigabytes of data. One of the key deliverables from this work, from privacy analytics, was our re-identification risk determinations. And in my words, what it does is it provides an independent, objective view from the privacy analytics experts on how we've applied the methodology that we've deployed. And so, for example, for Alberta Health, we had 6 linked data sets: physician claims, patient registry, the pharmacy information network, vital stats, emergency room, and hospital inpatient visits. So we linked that, de-identified, and applied our methodology, which would include the contextual factors that you heard about earlier, which includes privacy and security, recipient trust, like, have we worked with this researcher, with this academic institution in the past, and the sensitivity of the data, is it HIV data? All those contextual factors will present a risk score that we're driving towards. And so, again, in my terms, we need to throttle up or back on the amount of anonymization techniques, whether masking direct identifiers or looking at other techniques of de-identification for the quasi-identifiers. And so I'm happy to report that we did successfully receive the report, written report, and we're working well within the bounds of an acceptable level of risk and the application of the methodology for that particular data set. And what it does is it demonstrates an early win for our team, our development team. And it lends comfort to the privacy experts and our sponsors in our ability to release what was identifiable data. It's now de-identified. It'll never be zero risk, but it's delivered in a manner that's deemed acceptable risk. And for us, that was most important. And for Alberta Health Services, it wasn't necessarily a research request. It was a non-research request for educational purposes for a graduate class. And so we took a subset of the discharge abstract database and the National Ambulatory Care Reporting System, so data knackers, and linked that data, and now can provide that for educational purposes. So very different uses right there. And we are embarking on another use case, which is, and I don't want to refer to the Australian example per se, but what it does is it takes more of a complete set of data from DAD, separately from knackers, and provisions that data through our health analytic portal more broadly for research and other purposes. Through authentication registration, so it's not public, it is available but somewhat controlled. So where are we now? Now we have a framework for quantifying our risk of re-identification, and we can defend that. And I referred to the contextual framework for that. We have the tools and knowledge now and the process and so on to mitigate risk of data disclosures that might perhaps be breached in the past. Eclipse and related DID methodology is now incorporated into processes for data disclosure in the future. That's the method we're going to work with. And it really provides, as I said, a foundation for consistent, defensible, documented releases of data. And right now we're working towards operationalizing the new service, so transitioning to operations and really figuring out, okay, now when the real world hits, what does it mean when we have an intake of a request? What do we do and how do we do it? So really testing out those theories. Okay, some of the lessons we learned now, in my mind, these are really key. Managing expectations. Obviously, it seems so simple, but I think what we tried to do initially was too much. We tried to take too large of a data set and de-identify that. As we took a time out and a step back, we took another approach in getting smaller wins with smaller subsets of data. That was really key to demonstrate that it can work. We do know what we're doing, and we can continue building on that. Over-communicate. This is a very large provincial initiative, and where we thought people knew, even internally in our teams, whether over 100 stakeholders, that wasn't always the case. And I think that's such a key lesson is, say it 3 times or communicate it 3 times in writing or otherwise. I mentioned the small subsample of data. A real wake-up call for us is that, there's no that was easy button. It's not an appliance. You don't plug it in and then suddenly you've got a DID service. It takes work and it takes effort. And I would highly recommend that you have dedicated leaders on this. And I could clearly see between the 2 organizations where some were having success and some weren't, and why. So I think having the resources required for the development is key. And you bet, we have our day jobs, I get it, but if we're going to be successful, you've got to dedicate the time to make this happen. It just, like I said, it's not an appliance and it's just not going to happen on its own. We found that because Alberta Health Services works very much remote in nature, and our vendor partners were remote in nature, that was challenging. I'm not going to kid you. It was hard because we had presentations being shared, we had teleconference lines, we had link lines, and it was challenging at times. So, that's a lesson learned moving forward in dealing with that. As I mentioned earlier, we dealt with vacation time in the summer, and key people, privacy, analytics, or otherwise, were just simply not available. So to move through a rapid deployment of those 90 days, bound by the grant parameters that we were working in, was so important. Personally, I wish, I know privacy and IT security were involved, but I wish they were involved earlier and often and often and often, because downstream, as we're moving towards, going live, and the implications to OIPC and our privacy impact assessment, that would be a key takeaway and something I would change in the future. Obviously, changes in team members, we can't help this sometimes, but it does happen, but it was challenging for us nonetheless. And once, personally, I found that one champion in each organization that could grab hold of this, because I found, a lot of people were interested in looking at it, and some left, but some really took charge. And it's identifying who is your champion and how can they help you lead to success. And again, a consistent provincial approach to the methodology and the classification of our data variables was another lesson learned. I think what we thought was everybody would de-identify the same way. Everybody would classify these data variables, 150 or 200 variables, the same, and they didn't. So we had to come together and have a bit of a think tank to say, why did you classify this as such versus this? Because it ultimately affects your risk at the end of the day. And change management. Often that's the first thing that gets dropped. This is a change in culture. This is a change in how we're doing business. I believe, in my opinion, we're in the first inning of this, not just in healthcare, but in general. Like, we're seeing such a huge need and demand for data, and treating data as an asset and actually using it to improve patient outcomes. So driving, dollars and funding, limited funding, to programs that can improve patient outcomes. So our next steps, really, we want to finalize our governance and risk framework and really operationalize the solution. And already we've had a lot of calls around scaling and expanding into other GOA departments, Government of Alberta departments, and other, or ministries, and other AHS departments. So I think, again, we're just early stages on how we're rolling this out in the province of Alberta. That's 30 minutes.